Kim, could you introduce yourself as our speaker today?
Yeah, my name is Kimberly Price. I'm the RN manager here at NACC, and I do care coordination for our pregnant patients who are substance using.
Thank you. And then I'm Kari Rabie. I'm a family practice physician and addiction medicine physician here at NACC. Could you start the slideshow, please? So this is the Midwest Tribal Echo. Welcome, everybody. Thank you for joining us. Next slide. So we've done the prayer and land acknowledgement. Thank you, Renee. And I'm going through the introductions and agenda. I'll also go through Zoom guidelines. Tina will do, oh, did I introduce? No, I did, sorry, never mind. And then Tina will do announcements. Kim will be doing the didactic on CPS and prenatal care. I'll be chiming in. We're not doing a case presentation today, and then I will close. So for Zoom, please let us know you can introduce yourself in the chat with your name, title, organization, email. Know that you can update your name on your screen, right-click your image, and you can put your name in so we know who you are. Next slide. And we really like it when people turn on their camera so we can see them, and it makes for a better experience, especially for the speaker, and also so that we can have more personal discussion. If you would like to have attention, use the chat or the hand raise function, and then please mute your microphone when you're not speaking. If you do not mute your microphone, we may need to do it for you. Please don't take offense. It's just because a lot of times there can be unexpected background noise. Always no protected health information. Tina, go ahead.
So some announcements, just as a reminder, this ECHO meets every first and third Wednesday from noon to 1 p.m. Upcoming ECHO sessions. So the next session, so it says December 1st. I apologize. The next session is going to be November, what would that be? November 17th. And that is still to be determined. And then on December 1st, China Pfeiffer from NACC will be presenting with Dr. Ryan Kelly. They both do harm reduction work and advocacy for people who are hospitalized. Should be a good presentation. I don't know exactly what the title is yet, but that is on the schedule. And then just a reminder about other ECHOs. There are other ECHO projects happening, and even on this page, these aren't the only ones happening. But there's the viral hepatitis ECHO on the first and third Tuesdays, and then the integrated opioid and addiction care ECHO every Thursday. More ECHO information can be found on the Hennepin Healthcare website. Case presentations. So case presentations often, well, sometimes are included at the end of our presentations. And it's just a time for people to present like actual scenarios that they're encountering, and for all of us to just discuss and share ideas and knowledge. If you have a case presentation that you want to bring to this ECHO, you can submit your idea. I have a SurveyMonkey link that I can send out to everybody. And that SurveyMonkey link will also be added to our website on the NACC ECHO webpage. It's not on there yet, but it will be up there soon. Or you can just send me ideas directly to my email. And continuing education. So continuing education credits are part of this ECHO. And so if you do want to receive CMEs, you'll have to complete the survey that I email out to all of you after this session is over. So if you could please, in the chat, you can chat me privately or to everybody. I just need your name and the organization that you're associated with and your email address. And then I can just have your email down, and I will send you the survey link after we're done. And then the disclosure, all planning committee members of this educational event have reported no relevant financial relationships with commercial interests. And with that, I will stop sharing and hand it over to Kim.
Okay, well, let me see if I can figure out how to share this. Here we go. Is that sharing at
Yep.
all? Okay.
Yes.
So I'm going to move this over so I can see it. So again, my name is Kim. I am the MAT OB care coordinator over here at NACC. I have been working here with MAT since it started in 2016, and I kind of got just put into the OB role because we needed it, and I had women who I was already care coordinating who turned out to be pregnant, so it was a learning curve for me. But then I just really liked it and kept going. And so we're going to talk about CPS, one of the more difficult things to talk about when you are working with women who are coming in for help or in various stages of their recovery or use. And we were really excited in July. There were some pretty good changes for the state of Minnesota with regards to mandated reporting. So today we're going to discuss opioid use in pregnancy in general, briefly discussing the changes to mandated reported that happened in July of 2021, and then discussing engaging with patients and how to discuss mandated reporting, when to report, things like that. So generally, in prenatal care, our population is about 85%, would you say, Native American in our clinic, and in general, 27 to 51% of Native American pregnant women aren't receiving adequate prenatal care, and that increases infant mortality rates. That when people delay care or get insufficient prenatal care. Some of the barriers that we recognize to prenatal care, which if you're already providing prenatal care, you probably see this already, is that pregnant people often delay care or don't receive care because of concerns with reporting. Oh, is this the right slideshow?
Okay. Just go through the slide quickly. This one's
all right. So opiate use in pregnancy, 1 in 10 opiate use disorder with Native American pregnant women. And there's 8 times a higher rate for neonatal abstinence syndrome for Native American children, babies. And if you're not familiar with that, that's when they have the withdrawal from opiates after delivery. There's a misperception sometimes with people of what opiates have an effect on the pregnancy, and really it's the effect of the withdrawals that have the biggest effect, which can cause low birth weight, fetal demise, and preterm labor. And then confounding factors consist with that chaotic use, with women coming in, connecting with care, having that ongoing use, and then other things like tobacco use, which causes low birth weights and things like that. And then of course we see women, there's a risk for overdose still, and women can often sometimes not have the understanding, or people that they should still be carrying Narcan and things like that, and try to reverse overdoses if they do happen. Then there's also the risk of infections that can complicate the pregnancy as well. Like endocarditis is still a risk factor with IV drug use, and those kinds of things can have an impact on the overall health of the woman and how are they able to maintain a pregnancy. So pregnant women, they're kind of in this category of their own, where people are more stigmatized when they come into us often, even by partners who are still using. The perception is that women, that people shouldn't have to use while they're pregnant, and people still have the same withdrawal symptoms, they still have the same cravings, the same struggles, and it can actually increase as the pregnancy goes along, as their metabolism changes, as their stressors change. And then having the outside influence of, well, you're a mom, you should just be able to stop, you need to think about the baby, creates this stigma of, I'm not a good parent. I can't be a good mom. Why can't I stop using? Moms really come into us and they are, sorry, is my microphone acting up?
Just, I think it's rubbing on something.
Okay, I'll just hold it out a little bit and see if that helps. So, I'm sorry, they women come into us sometimes and are saying things like, I don't want to, I can do this myself. I don't want to be on some kind of MAT. I don't want to use. And then it's really hard to maintain that sobriety during pregnancy for a lot of reasons. But there's also this idea that that's a failure, and how come I can't do this? We hear a lot, or have heard a lot in the past, why can't they just stop? I would do that. I quit smoking when I was pregnant. And it's not a lot of women are able to do that. The withdrawals, the cravings it can even get stronger, and we encourage women to continue on when they're engaging in MAT, to continue on through their pregnancy, not tapering off. And we notice that sometimes their needs even increase during pregnancy because of their metabolism. So there's also pressure from family members, sometimes even partners. And like I said, partners that are still using may not understand the difficulty in stopping during pregnancy. And then there's also they don't want to see babies go into withdrawal. And so kind of talking through the withdrawal and what happens when babies withdraw after delivery and what that means for their treatment during pregnancy can be really helpful too. And if you guys have questions about that, we could talk about that later on if we have time. But
yeah, and I just wanted to make the points that that when you look at the data, it definitely shows that women who engage in MAT, like those babies have first of all, women who are in MAT are much more likely to be sober when by the time they deliver than a woman who chooses the abstinence-based model, meaning that they try and stop entirely. Just because, I mean, the reality of the situation is the cravings are very intense. And it's very difficult to get through an entire pregnancy and to stop using on your own. And then the other piece is that when they look at the data, the women who are using or who are on Suboxone their babies have a much lower rate of withdrawal than any babies, including those women who chose an abstinence pathway because of the use. And then the withdrawal with buprenorphine or Suboxone is less than it is with other substances.
Mm-hmm.
Next slide, please.
So we just want to talk about the history of child removal in general, especially in the Native community that we work with in particular. And that started back in the 1800s and has caused ongoing historical trauma and trauma when it comes to removing children today. So again, starting in the 1800s, the government started removing Native children away from their families forcibly and putting them into boarding schools, causing them to change their language, the way they practice their culture, the way they look, the way they dress. There's a lot of abuse history that goes into that as well. And we see that even with parents and grandparents here who still in their time frame were being removed from homes and put in boarding schools. So there's this historical trauma with the patients that we're seeing here in the clinic and potentially their parent as well. And in 2016, Native American children were more than 17 times more likely than white children to be removed from their homes for the particular reason of parental drug use. So when we talk about mandated reporting, Minnesota historically has been, we'll see some slides later, that they seem to be a little behind on the curve of the mandated reporting. So they were, substance use in pregnancy is still considered to be child abuse. It can be grounds for civil commitment, so removing the autonomy away from a person who's pregnant. And then it requires that healthcare providers, it did require that they test for prenatal drug exposure if they suspect drug use. And then Sorry
There you
about
go.
that. Okay. So,
Can we go back?
oh yeah. And then Minnesota also, we do have drug treatment programs, and the perception is that women who are pregnant should be ahead of the line and they should be first to get in and they have priority, and that does not always give them priority. So we see women who are anxious and ready to get into treatment and are on these waiting lists, and treatment can be, it creates that stability, and it creates this history of they're in a treatment program, and when they go to the time of when they're going to deliver, that's super important for them to be able to show a social worker or a CPS worker that they're in a program. And so if they're delayed and delayed and delayed, they might not have that stability available to them when they're going to give birth. So probably all of us are mandated reporters, and when you talk to people about mandated reporting, that's a really hard conversation, and it causes a lot of mistrust with us as providers to be able to have that conversation with people when they know that the answer is going to be, I'm telling you I'm using drugs and you're going to report me immediately. And so people who are misusing drugs during pregnancy have been shown not to trust their healthcare workers and not disclose their drug use, and sometimes even delay getting care through later in their pregnancy or at all. And we know from the data that's available to us that among Medicaid people, 34% of pregnancies with NAS received inadequate or no prenatal care versus 14% of all for non-NAS births. So when you're delaying or not getting prenatal care at all, they have a higher risk for, those kinds of outcomes for baby. So this is just kind of some graphs. We're going to blow through these because they're, it's just kind of showing you the instances of the Native American people entering care for a drug use reason. And the child, you'll see in these next slides that Minnesota is always highlighted in these states as people who are one, seeing it as child abuse leading to commitment. 1 in 3 states. Healthcare workers have to report drug use during pregnancy. States that were requiring testing during pregnancy. And then just a mention of ICWA. So in the 70s, the country did come up with a way to try to keep Native American children inside their own community, whereas before they were being massively put into households that were not in their own community. They weren't with their family members. They weren't looking into the community to find the placement for those kids. And so they were removed from their homes. So now they have ICWA, who if they're tribally enrolled or a descendant of a tribal enrolled person, then they start to work with ICWA as opposed to CPS. So when you call CPS, they ask you if the person is tribally enrolled and assign any kind of case to the ICWA worker. So the new changes that came in 2021 in July are that if anyone would come into us previously and they disclosed that they were using any kind of substances other than marijuana and alcohol, even in a primary care setting that was providing prenatal care to that person, we were required to file a report to CPS with a verbal report within a certain amount of time. And then they would file that basically. So now, as of July 2021, people who are providing prenatal care and who are working with those people around their prenatal care, as long as the patient is engaged with their prenatal care and not lost follow-up, then we're now exempt from having to make a report. That I just want to touch on something that, there is a point where CPS reports, based on your judgment and your interaction with the parent, might still be necessary for the safety of the parent or the child. But this gives us so much more leeway to work with patients when they're here in the clinic and continue to keep them engaged, continue to keep them in a trusted relationship, with their provider and have frank conversations about their use, instead of having somebody come in and tell us that they're using and knowing that there's that immediate reflex to a report. We had already stopped mandatory testing for with UTOXs at the clinic a while back, maybe about a year and a half ago or so. But with our patients who are coming to us for help, patients who are coming in and saying, I want help for X substance use, it's really difficult to ask for help with a substance use disorder if you can't say that you're using a substance. So that created a huge barrier for people to come in and ask for help, get onto an MAT program. So what we kind of did in that way was talking through with the patients, being really frank about that, and working with them, having that transparency, talking to them ahead of time. We are mandated reporters, and here's what that looks like. And now we have that extra conversation with them that says we don't have to report anymore if you're engaged with us as your prenatal care.
And that has the added benefit of an incentive for women to stay engaged, even if they're continuing to use, which is just more opportunities for engagement and for motivational interviewing and to see where people are at. And to be honest, and of course, most women are hoping to be sober by the time baby's born.
Yeah, and we kind of talked about this in a different slide, but I'll just bring it up on tailing that is that sobriety is usually not a straight line or a straight road, and relapse is part of that journey. And so if people would come into us and ask for help, then fall off for a little while, then come back, and every time it was this conversation again about, well, can I disclose my use? Can I tell you about what's been going on with me in the last month where I haven't been in? And now we can kind of follow them through that journey and work with women and up until their time of delivery. And so it gives us a lot more leeway and trust with our patients. So this is the actual law. So you can see that the part that struck out is that their use automatically would trigger a report. But now if they're the part that that's a little bit vague, but people that are collaborating with other professionals. So I think that includes social workers, caseworkers that are involved in that person's care as well. As long as those people are consistent, then they can also defer to this law to say, I don't have to report that either. Okay, so we talked about this kind of already, but patients can engage earlier with their primary providers without fear of the mandated reporting. What we see a lot is our patients tend to either come in really, really early and try to start that sobriety journey right away, or they delay their care more and more and more. We have a lot of women who come in post 20 weeks, post 26 weeks, 30 weeks, and haven't had any prenatal care, don't have any imaging, often are extremely emotional about how they're perceived, how their pregnancy is going. Some of them haven't even heard baby's heartbeat yet. And that is a really powerful thing to be engaging with them. It looks like we might have a question.
The question is from Jessica. One of the issues that I've noted with the new legislation is that many people are not aware that we still have to test. We do still have to test and report as needed if the baby tests positive. Is this something your team shares?
So
do you want to take that question, Kim?
I guess I'm wondering if that's postnatal. Is that?
Yeah, I think that is what they're talking about. So yes, and I think that is something Kim and I we definitely do is we have that conversation with the patient that if at the time of delivery they're still using, absolutely there will be a report to Child Protection. But we still use the same kind of guidelines of Project Child. We say, a lot of times they're looking for some stability, and if you can be abstinent from drugs by the time you're about 32 weeks and show that you've been stable for that period of time, like 2 months, then you can usually go home with your baby. But we definitely are telling them that by the time that CPS can get involved, actually at any connection with the hospital, CPS could get involved. So we don't, you know, for a person who's chaotically using, they're not in a safe space to go home with a newborn infant. So, you know, the CPS has a role to play in all of this. It's just like getting involved right at the beginning of the pregnancy is not a good thing.
And the other thing is that, you know, when we're engaged with our patients here, we kind of have conversations throughout the pregnancy and their prenatal care. And as it gets closer to the time of delivery, you know, we understand that you know, sometimes hospitals just test mom if she's on Suboxone, even if it's prescribed, or have a history of known substance use. And, you know, I guess it depends on which hospital, if they're routinely checking the meconium and things like that. But having that conversation with moms, preparing them for the fact that they may be called, a social worker or a CPS may be called. But if we prepare them for that as a possible thing that happens, and kind of talk them through what that looks like if they find, you know, they are gonna find that in baby's test, and then what they'll do is they'll call a social worker, and we're here for you because we've been with you through your pregnancy. We can show that you've been stable. You can show that you've been stable, and we have a lot of women who end up meeting with the social workers, having that social worker see that they're stable, and then going home with baby. So kind of talking through all of those possibilities and preparing them ahead of time so they're not just blindsided by it is important. So even with the change in the laws for primary care and prenatal care, and again, this kind of goes to that question, this is like prenatal care that we're talking about for the most part. There is still a lot of fear with pregnant women who are using, and they still often to the point where they're refusing to come in at all, trying to deliver at home, or trying to avoid going into the hospital when they're in active labor, because they have this fear that they're going to go in there and their encounter is not going to be a positive experience. And so we're still having those conversations every single time the pregnant person engages with us, that this is, you know, we are mandated reporters. Here's what that looks like. Here's what that looks like as you're going into the hospital. But look, here's these awesome changes that have happened. Because, you know, I even had a woman very recently come in at 30 weeks, had no prenatal care, and she is trying to get on MAT and said to me, I don't know if I can tell you this stuff. And so we just talked about what that means, and you're here now, and you know, I am a mandated reporter, but hey, look at all this awesome stuff that's happening. Me and you can talk about it really, really directly, and I don't have to make a report right now.
And even if a woman is, like, we had another instance, you know, somebody who also engaged about 30 weeks and then didn't engage again, and then it was at term, and we, you know, she didn't come in she only came in one time, but then when she got to the point where she thought that she was going to deliver, she didn't want to go in, but she called us to advocate for her at the hospital. So she felt more comfortable going in if I just called the hospital and let them know who she was and all that, and what was going on with her. So we become advocates too, even, you know, for women, whether or not they're sober at time of delivery, we become a resource and in advocating for them with the hospital system, and it just gives them a little bit extra level of comfort in a very scary situation.
Yeah. And again, some of our patients too come in with very, very little social supports. So if we can be that, you know, that expert help with them too, who can advocate, that can be, and even just encouraging them to advocate for themselves too can be really powerful. So we at NACC have a really big harm reduction approach, and I think that is I love that about NACC. And that's another thing, as we're having this really scary conversation with women about CPS and what does that mean and what does it possibly look like, and here's this scenario and here's that scenario. just kind of letting them know that we're on their side. We're here for them to have the healthiest pregnancy that they want. We're here to help them, their goals, to get them home with baby. And, you know, talking about that right away, it comes pretty organically, because you'll see the hesitation when patients are coming in to talk to you about their use, or even if they don't want to quite talk about their use, there some body language or indication that they're concerned about something. And so it usually comes up pretty easily in conversation. Then you can just say, okay, let's talk about that right now. And it's kind of that thing where you got to practice it to get more used to it. And then it just becomes, if I'm calm about it, then maybe they'll be calm about it. Kind of normalize.
The other difficult conversation is when, you know, just to make sure that you're speaking with every woman about chemical use during pregnancy, regardless of whether you're picking up on any vibes or anything like that, just to say, you know, we don't talk to everybody about this, and we just want you to know that if there was use, or if you are using, we would still see you. You know, we don't have to report, right? You know, I had the conversation with everybody, and that conversation a lot of times feels very awkward, because, you know, especially if you're speaking to patients who are not using, and they're like, why are you having this conversation with me? And we say we have with everybody, and we also want, if you know somebody who's using, we want you to be able to tell them that this is a safe place for them to come.
Yeah, and where I kind of insert that into the conversation when I'm doing their intake is we don't routinely test for, you know, when I'm going through all the labs that we do, we have on there like urine toxicology, not routinely done, but it can be done on request, and that can kind of be an opening, because that's for everybody's conversation. We're doing all these routine labs, and this one's optional. And how do we talk about it at that point can kind of ease into that conversation too. And make it feel less blaming or accusatory. So then the other thing about talking to women about CPS is there is a possibility that CPS is going to get involved. And some of them even come into you and they're already involved. And if there's CPS involvement or a case open, then CPS is going to be involved throughout this pregnancy as well, and maybe making certain requirements for the person. So offering services on how to navigate that. We have patient advocates, we have LADCs, we have options for women who are trying to navigate those CPS requirements too. And trying to be on that same side. It's like, we're here to help you be successful in where you want to be, and how can we help you do that, instead of trying to tell someone what to do to make that happen. You can give them all the information and say, yes, if you're on track and sober and working with our MAT program by 32 weeks, that puts you on a really good track to have your outcome be really positive at the hospital. And kind of talking about it in that way too, where we can talk about all the options and all the outcomes, but we're trying to get you home with baby. And then we talked about this already. There's if the part of the mandating is that if they're lost to follow-up, which happens not infrequently for pregnant women who are using, because their lives are really chaotic. They might have all these outside socioeconomic things that impact their ability to come in on top of their substance use. So again, we should be assessing that ahead of time, like rides and things like that. But if they are lost to follow-up, then we're supposed to report. And that's really difficult for me as a provider, because even if we have to report somebody, I like to have that conversation ahead of time. Hey, this happened, we need to call CPS. And if you're lost to follow-up, there's no way to have that conversation with people ahead of time. So trying to continually, we have care coordinators who we continuously reach out to them if they no-show their appointment, or we know that they've just kind of haven't been coming in and they're getting to this point in their pregnancy. Are there outreach people that we can get to reach them if they're, for instance, at certain camps, or do we know that they're working with healthcare for the homeless, or you know, what are those other resources that we can try to find them and get them back engaged? And then also just realizing, like we said before, that relapse is a part of recovery. So a lot of people have this very tumultuous beginning in their pregnancy, and helping them to just continue to be engaged and encouraging them for the successes that they're having, and recognizing that that's not different when you're pregnant. So then what if you have to report? Again, all of this is a little bit repetitive because we just want to stress, like, talking in that transparency with people at the beginning and then throughout the pregnancy is really important, because then people won't be surprised. And sometimes even just having one conversation with somebody, they're not in the right mindset, perhaps, to even just be listening to that, what you're saying to them. So just kind of revisiting it when it's appropriate, I guess, not making it the focus of every visit, but, and then if we have to report, what that report means, why it's being made, offering supports like Project Child, who's some of our patients have found really, really helpful, but even that I don't honestly know their resources right now. I think they're a little bit more difficult to get connected with, but, and then the things that we have already said, if they can be ongoing and consistent with their appointments, have a medical connection with us here at your prenatal team, if you're engaged with MAT, then we can show that you've been stable and you're working on sobriety and you're safe to be going home with baby. If people report, I don't think that this is different at all. And so if anyone else has any other experience, when you call in a report for a patient that doesn't have an open CPS case, you call and you give them the report and they end up filing it. It doesn't open up a case because they don't open cases for unborn babies. They'll just keep it on file, and then if there's a report made at the time of delivery, then they can see that that it was filed at an earlier point in their pregnancy. But a report during a pregnancy doesn't mean that there's going to be an open case. So even just having that conversation with the mom too is important when they hear that they're going to have a report made against them. But it does, I don't see a lot of the mistrust with our patients with the CPS reporting, even when we have that conversation with people. But I think that has to do with the work that we do from the beginning, that we have fostered that trust with patients. They see that it's a thing that happens or could happen, but we're really transparent with them and working with them as opposed to working against them. And then we also try to stress that there's so many resources too that can be tapped into when you work with Project Child or when you have CPS worker, if that ends up being the case, and trying to tap into those resources that they can get. And then we already talked about the testing at birth. So just letting them know we're on their side. Assessing their needs is super important too. Finding out what are the barriers to getting to their appointments. Do they have stable housing? Do they have safe environments? Do they have a safe relationship? Are they, trading, doing sex work and things like that? And how does that impact their ability to come to their appointments? If they're in a shelter, how does that impact their ability to come to the appointments? We have started working with some outreach and trying to engage patients while they're not able to come in too. So that's another thing to think about. HCMC brought up the labor and delivery. What we try to do is find out how our hospital systems work, because patients come into us and they say, well, I don't know where I should deliver. Where's a safe place for me to deliver? Where is there a team that I can trust where I'm not going to be treated with disrespect or stigma because I'm on Suboxone? And it's really important for people in labor and delivery and people in that postnatal setting to realize that especially if they're engaged with somebody, that's been a pretty long journey, and MAT services are not use. That's a It's a recovery, it's a medication just like any other medication. And it's not a short falling that women weren't able to get sober during their pregnancy. So we want that birth experience to be positive. We want them to be in a place where they're treated with respect. And so we work with hospitals locally to give those options to our patients. So this is really important. They often are treated, report that they're treated poorly or treated with like, kind of a side eye, even just certain glances or a tone of voice when they're in delivery or in the postnatal. And, it's really, women are really worried about babies having withdrawal, and they want to stay with baby and they don't want baby taken to the NICU. And women can become disheartened by even just the way they're treated after baby is born if baby is having withdrawal. So kind of thinking about how you're approaching moms when you're doing that as well.
And Kim, did you want to talk about the NAS protocol too that we go through with them?
Yeah, so we have a packet of for the neonatal abstinence syndrome, when we talk to moms at the beginning of the pregnancy, just when they're trying to get onto Suboxone here. And then we talk about it later on. The biggest thing that I would say that patients have questions about is, what does that look like at the hospital? Are they going to take baby right away? And in our experience, there's not many hospitals around that do that. They monitor baby, and I think it's usually they check baby, then they check every 4 hours. If there's 2 or more screenings, is that different, Dr. Rabie?
Yeah, no, I just noticed that Renee had something to say. Yeah, and that's right. And then also the Eat, Sleep, and Console can empower the mom to get involved in making their baby feel better. And I'm sorry to have interrupted, Kim, but Renee, did you have a question?
That's okay.
Yeah, well, I had a comment, just, culturally and spiritually, for Native American women, there are, it would be good to have a resource or a spiritual person that they can go to, because there's rituals around, putting the placenta back, giving the placenta back to the earth. There's a ritual with that. And then what we do with the belly button when it falls off, there's a ritual with that too. And I think it's so important to connect them with somebody that can get a spirit name for the baby, and I think if they can do that, meet with somebody early, there's that connection, to really start caring with the baby and looking at the baby as a spirit, a spirit being, So I just wanted to add that. Thank you.
Yeah,
Thank you.
Okay.
And we didn't really talk about the services we offer here, but that's, Renee is one of our elders, and we have another elder, and they can offer spiritual care here. We're really fortunate to be able to do that for a
I just
patient.
want to pop in and say that we have 10 minutes to one.
Okay. All right. So I think we're almost done here, but I don't want to miss any questions. So if people have questions and they think I might not get to it, please ask them now, because the biggest thing is kind of talking about integrating that harm reduction into your regular daily interactions with your patient. So trying to reduce the stigma and provide supports. And I think we've done a really nice job, and I feel super fortunate to work here because we do it so well that people come to us and they already have this perception that we're a safe place, so they feel comfortable disclosing a lot to us where they might not already. Renee, did you have something else? I might just be getting.
No, I'm sorry. I was trying to come down.
I have a question.
Yeah.
There was a brief mention on one of the slides about it sounded like using like testing to an advantage. So here's my idea, maybe this is already done, is that if they develop a relationship while they're pregnant with the clinic, utilizing UAs that would be hopefully nice and boring, you know, like nothing's showing up. And then if CPS even halfway wants to be punitive, you can show, well, we've got like 15 weeks of boring UAs.
Yeah,
So-
yes, we do that. And so that's a really good point. If anyone that's in our MAT program, they have to leave us a UTOX. And so we have that conversation. That's the only time when we, you know, do it routinely, but that's part of our MAT program. We want to make sure that it's in, that their Suboxone is in their urine and things like that. And we talk to them right away about how this is not a way to try, you know, to come down on you. It's a way to have a conversation. And then there's also that, yeah, if you can have all these clean urine screens, that's a really positive thing.
And also we don't check for things like marijuana in our urine.
Yeah. And the other thing too is that patients should be aware that when they sign releases for things, one, they can take those releases back, even if it's for CPS. And they can also put date ranges on it. They can say, you guys can have access to my UTOXs from this day to this day or whatnot. So kind of advocating for them, and that they have the power for their own information too. So we really want women to get in the door. So things that we've done to try to do we've started doing outreach at Avivo. We're trying to give away prenatal vitamins. I haven't been to Avivo in quite some time now, but when we did go, we were offering up, you know, bags for pregnant women, and having a conversation without you telling me your name, so that you can talk to me about your pregnancy. Are you getting prenatal care? What should prenatal care look like? Or that should, what is ideal? Where do they plan to deliver? Do they have any questions? Do they have questions about CPS and reporting? And if they want to, hey, we're a connection for you, or we can help you get connected to somewhere where you're feeling comfortable and you can be seen there. So that has been really nice. And then we have been trying to work with outside partners like Avivo, like Healthcare for the Homeless, like Fairview, HCMC, those other systems where our patients are often engaged with as well, to create warm handoffs and referrals and things like that too for our patients. So we just talked about that. You know, the other thing women sometimes, people don't have all the resources that they need even to know what to look for pregnancy. So just having that information available, even if somebody's not ready to engage in their prenatal care, what are danger signs in pregnancy? What does it look like for signs of labor? What does it look like? What should I be looking for baby? And that I should be maybe going to be seen for. So, well, yeah, we're skipping a little bit of this. Are there any questions? I know we have 5 minutes left.
Yeah, that would be a good idea to pause. Do you want to just finish the slides just so we can see?
Yeah, so we just, talking about breastfeeding, kind of empowering women to realize, like, using drugs, having used drugs during my pregnancy doesn't mean X, Y, or Z. So I had a woman who thought that she couldn't vaginally deliver if she had hepatitis C. That's not accurate. And so kind of reinforcing those things, you can still breastfeed, you can still have a healthy pregnancy if you have hep C, you can still do all of these things if you're on Suboxone, and kind of empowering them to say, like, I don't have to try to do this alone is also really important too. And then continue.
We have to go through the slides. Let's just scroll through them so that we can. Yeah.
So then kind of remembering that postpartum is also really important, giving people resources. Yeah. And yeah, exactly. Relapse. So their journey isn't stopping, and in fact their stress level is increasing after people are delivering. So yeah. Renee.
I just wanted to, to add that if you have a grant writer in your department or your program, or if you have resources, it's really I think a good idea to have like resources where they can make moccasins. We've had that in the cities where we call it first gift, and it's so important for the babies to leave, the hospital with moccasins, or even how to make the amulet where you put the belly button in, those kind of things, and getting the mothers engaged while they're pregnant in these things I think it really builds that connection. So that's all I wanted to say.
Yeah. And there are other resources too in the city. The Indian Center has Bright Beginnings, which is aimed at women who are who have had substance use in the past and are either pregnant, and I think they go up to 2 years, and that creates this beautiful group of support. And they do things like making ribbon skirts and meeting once a week down at the Indian Center, and they can self-refer or I mean collaborative referral over to them. Any other questions, comments?
Is there such a thing as having, maybe it's random, but having a favorite CPS workers for this specific issue?
We used to.
Okay.
Yeah, we have, I mean, we have had people that have been, who have worked very well with our patients. Right now, I don't think we do. But we definitely, you know, sort of, we know, you know, we have preferred providers and preferred hospitals that we send people to, and contacts that people that we know that are sort of working on the same wavelength around harm reduction and respecting women regardless of where they're at.
Mm-hmm.
I have a comment. I think one of the things we do really well, I'll just kind of like brag about us a little bit. We have a little kind of snippet in every intake about if you become pregnant. So we kind of have that conversation even before pregnancies even maybe thought about. And hopefully that helps kind of lead to that feeling of trust and being able to come to see us if you do become pregnant. So just something that might be helpful.
Renee, did you have another comment or question? Oh,
That hand just don't go down.
Well, thank you guys for letting me talk. Sorry, I got a little rushed at the end, but you can always let us know if you have questions afterwards.
Yes, and hopefully we'll see everybody on November 17th? Yes.
November 17th.
Okay.
I'll let
Right.
everyone know what the topic is. We don't know what yet, but the mystery.
Okay. Thank you. Have a lovely day.
Thank you, Kim and Dr. Rabie.
You're welcome.
Bye.